Live. You're ready to go when you are, Dr. Finger.
Okay, thank you very much. Good afternoon, everybody. Good to be with you in the strange environment of distance learning. I hope all of you are safe wherever you might be. And today, I'm looking forward to sharing with you my experiences in using digital dentures. And you might say, what is a digital denture? Well, I'm going to be showing you how we use software to plan, to set teeth, make a denture in either 2 or 3 visits using current technology, just as we do in fixed restorations, where we scan preps and plan our crowns. And we'll show you that you do not have to go out and buy expensive equipment, rather that your labs are going to do this, and you can utilize digital technology using all your own clinical experiences and the same clinical techniques that you've been using to do removable prosthetics. I'm in New Orleans, home of the Mardi Gras, truly a hotspot. Unfortunately, after our Mardi Gras this year, New Orleans became a hotspot for COVID. Everybody was so close that it's suspected that a lot of this was transmitted. But in the new year, we've had your group come down to New Orleans. It was great. I'm looking forward to you coming back to see our wonderful city. So today, I know that doing dentures is a passion of mine. I have a practice where I treat the edentulous patients. And I view this as total oral rehabilitation. Patient doesn't have teeth, and I'm going to give that patient teeth back. Dentures. Who wants to listen to dentures? Well, it can be quite exciting for me because I'm restoring a patient to true health. I'm going to ensure that I can get them back psychosocially, as I will show you, back into society, and that with their teeth and with a good set of teeth, they will feel very comfortable. In addition, obviously, to doing my complete dentures, I do treat implant over dentures and I do hybrid dentures. Today's lecture really will be focused on the complete denture. I will show you a couple of implant procedures that can be done with this, but really I wanted to bring you the technique and to give you an update of what is happening in the implant world. This article was written tongue-in-cheek, where we were speaking about viable options to implantology. And something we need to recognize is that in the United States, there may be about 40 million people who are edentulous. And realistically, while the state of the art says it would be great to give everybody 2 implants in the lower arch to do a hybrid restoration, essentially, the standard of care in our country, or in my country, is complete maxillary and mandibular denture. And it's only about 2 or 3% of our entire population, essentially, who are getting upper class dentistry or implant dentistry. So how do I make a denture and how do you make a denture? We all have clinical techniques that we utilize that we might have learned very early on at dental school, but we've thrown those techniques out of the window and we change our techniques to suit our own clinical practices. I generally will do it hopefully in 5 visits. And then after that, there's appointments to adjust and adjust and adjust. You may have patients that you have to do a couple of setups. But essentially, I'm going to make an alginate impression. I'm going to make final impressions, and I can utilize different kinds of materials depending upon what I see in the mouth, where it's a flabby ridge, whether I have different materials. And then from there, I utilize wax rims. I sometimes use a face bow. I should tell you, in Louisiana, many dentists are using face bows for when they go fishing. They use them for kind of sinkers. I know that's silly, but just to add a little bit of humor here. And then we adjust the denture base. You can use a Gothic arch tracer. These are all techniques which are common to all of us. And we go ahead, set the teeth, try them in the mouth. And then we use the lost wax technique to finish our dentures. Here we have the dentures finished. The teeth, this is a class 2 patient. Teeth in position. We've positioned them for phonetics and aesthetics. And we say, okay, got a complete set of dentures. Currently, I am involved in doing a number of dental surveys with my colleague Paul O'Lynn, who's the Associate Dean up at the University of Minnesota. We give denture courses over the past 8 or 9 years. I've been out about 80 times doing denture courses. I've spoken to study groups, groups arranged by dental labs. And it's very interesting what our initial results of these surveys are showing. Many dentists do not like doing dentures. They don't like them because they have to adjust the dentures. They don't like them because of complaints. And they say patients have high expectations. You know, many of my patients will walk in and the first thing they give me is a Vogue magazine with a specific size of tooth and say, this is what I'd like to look like. And they're 75 years old, and I look at them and I say, there's no way that I'm going to be able to make you 16. I'm just thinking that, obviously. So many dentists would like to see a reduction of appointments if they can, and they do that. They'd like a quicker lab process time. And actually, patients themselves don't want to really come back that often for a complete denture. They feel that the appointments take pretty long time. So where are we right now? We're with the lost wax denture technique. Now, unfortunately, some of the videos won't show on Zoom, which I've discovered. I'll try and see if they do. But this afternoon, what I want to share with you, I started doing digital dentures using software with Avident in 2012. So that there's absolutely no misunderstanding here. Companies' names will be mentioned. I'm not selling any system. The main difference here between Ivoclar and Avident have a software program which is unique, it's proprietary. What they will do is they will sell you the software, and you can change the position of teeth after they have actually used their software to set teeth, but you cannot actually set your teeth yourselves. And then they will complete the dentures for you. You will send them your impressions, your records. They will scan these, or you can use what we call Avident Connect after you've scanned the dentures in the mouth and the outside of the mouth, the records, the impressions, and they will take it from there. There are many companies available on the market now that are making, and I'm sure you've all seen when you go to meetings, discs and pucks of different resins. There are a variety of milling machines out there. There are a variety of software programs, Trios, Exocad, Blue Sky, that you can utilize to set teeth. Ivoclar have a system. What Ivoclar has done is they have simply made materials, and they're saying, well, you can utilize my materials and go ahead and make a denture. And then, of course, there are printed dentures, which I've tried. I don't know how many of you are doing printing dentures. I've had the use of the Heraeus material with the Kera printer, a lab up in Buffalo is doing it for me. And those have worked out, but I have not found that their aesthetics is as good as the printed dentures. Sorry about that, but So what I want to talk to you about here is, let's have a look at the advantages that you might have if you are doing a mill denture. You can do it in 2 visits. In my office, I have a Itera machine, I have an E4D, I have a couple of milling machines. When I see my colleagues doing fixed, I thought it would be nice to be able to use the technology and go ahead and have a mill denture. So when you're milling, it is a you're cutting, and it is a reductive type of method. Let's have a look at why there are some advantages when you are doing and having a denture milled. One is that when you make a puck of resin, which is going to go into a milling machine, it's generally made under high heat and a tremendous amount of pressure. And studies have shown that we have a great reduction of monomer, that the base is very, very hard, and that there's no shrinkage once it's milled, as opposed to the lost wax technique, where there is shrinkage of the resin when you process your denture. In addition, Carlos Muniz found up in Buffalo before we started this, is that the first dentures that were being made were bases were being milled, and then with the sockets, and then teeth were being bonded. So he looked at the bonding strengths, the color stability of the resin, porosity results, and mono results. And he found that there was very, 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 very little monomer. And he also found that there was almost no candida growth on these bases, due to the fact that there was minimum porosity. And that comes from the fact that the pucks are made under high pressure and high heat. Now, these advantages that I'm showing you are available to all systems out there. First of all, because I'm going to be making an impression, making records, scanning these, and having the technician scan these, I'm saving an immense amount of time in constructing the denture. There's no setting of teeth in wax, there's no boiling out, and it is a clean procedure what you're doing. So technicians are loving this, and from the last survey of the National Association of Dental Laboratories, we find that about 10% of labs are beginning to use this technology in making dentures. So there's an interesting scale here. If you think about this, what our technicians do for us, many are designing your partial dentures. Many are telling dentists what type of restoration they should have for their implants. They help you select precision attachments. And it's interesting to see that this technology is being embraced by our dental technicians. And they will drive, I believe they will drive the market and say to dentists, come on, we need to move along with this technology. I'm not going to go into the results of the different surveys which we're reviewing right now, but the only thing I will note is that there are fewer and fewer hours being done in dental schools and devoted to removable prosthetics right now. So at some point, the technology which is available should become available to students, and they, I think, will begin to enjoy doing dentures. Oh, am I going back here? Sorry about this. I'm hitting the wrong buttons here. And then there are different ways you can add teeth if you're doing a mill denture. The first way is to mill a base. You mill your sockets, and after this milled base, the software has dictated which teeth you're going to have. The teeth fit directly into the socket. These can be bonded. What we have found, however, is once a base has been milled and you add a white resin to the opposite side of the milled base, you can come back and mill teeth and now have a monolithic denture. And you can have a dual layered with lucitone teeth or vertex resin. So I don't have the videos to show you, I'm sorry, but we now know that you can either have a denture which has bonded teeth or is monolithic. In other words, it's a one-piece denture. Now, from your group's perspective, the one-piece denture is a very strong denture. And what we are finding is that when it is being used for a transitional denture on an all-on-4, there has been a dramatic reduction of fracture of these dentures during the time that the patient is wearing this prosthesis. So from your perspective, if you're doing a lot of implants, this is one technique you might want to look at, because the transitional dentures are really, really very, very strong. So you get an XCL1 tooth or an XCL2 teeth, depending upon the shade that you're using. And hopefully we're finding that this type of fracture is being minimized because it is a one-piece monolithic denture. So if you look at the total mold denture, you have a base and teeth that have become one unit. You can custom mold teeth to any size that you would like. You want a wider tooth, a narrower tooth, you can position it according to the occlusion you want. And this will help eliminate the inaccuracy of having a manufacturer's tooth when you can actually mold teeth which articulate together. The other advantage, if you're using one of these systems, is that not a problem. As I told you, you have all the materials that you want, and these systems can use the material shades that are available on the market. The dentures granted will have to be finished still by hand, but you can create stippling. Border width can be milled to precise margins that you indicate on your impression. You can either have a posterior paddle seal or not. You can have your phenoms adjusted. So there are denture-based options, different colors. And then this system is being phased out. Originally, when we were having the bonded, if you want a bonded, you can still do a wax try-in if you want to get this back. But really, the try-in of choice now with all systems is either a milled white acrylic block, or alternatively, a printed denture for the second phase. And what you're going to get is you're going to get teeth on a block or a printed denture, and you can go ahead and try this in. You can use what's on the market. You can use tooth size markers, put this on impressions. Here I've taken impressions. I've actually made a jaw record on my impressions, decided what tooth size I'm going to do. The impressions are going to be scanned upper and lower. The bite record is going to be scanned, and that's going to be fed into the software. That's what the patient looks like before I send this off. From Avident, I get what is called a digital preview. They use their software, and again, I'm hoping that this is software of teeth in a library. You hit a button, the software, the teeth appear on a virtual mounting. You see this, you agree whether you like the occlusion or not. They have a digital preview which you can download onto your iPad, onto your computer, onto your phone, and you can go ahead and change teeth accordingly if you so desire, if you have the technology. But here we have the block. You're going to try this in the mouth. You can look at the midline. If this was printed, you can change the vertical dimension. You can decide if the aesthetics is acceptable, and you send that back, and the dentures are milled. The base is milled. White resin is added to the base. The teeth are milled, and the denture is delivered. So there's our happy patient. What about occlusion? If you're using different systems of software to set your teeth, you can decide that you would like to have different occlusal schemes. You can have anatomic to cusp. Against natural teeth, you can have individual articulation. You can have a flat plane. You can use 0-degree teeth, because all these libraries of teeth are available within the software. Then, of course, you can have a combined You can have linear or lingualized scheme of occlusion, and you can go ahead and let's have a look at why I prefer the lingualized scheme of occlusion. Oopsie. I think lingualized gives us an aesthetic quality. It's good on all ridges, not just the severe mandibular ridge. It can be used where there's a malocclusion, and it can certainly be used where patients had a previous type of any occlusion which may have caused some sore spots. The advantages are that there's freedom of the non-anatomic upper tooth. There is potential for bilateral balance, and I'll discuss that. You can centralize vertical forces, and you can facilitate bolus penetration because you have a lingual cusp against the flat tooth. Here it says potential for bilateral balance. Discussing denture occlusion is a whole different subject. I've been a dentist for 51 years now, started my training 56 years ago. And to be honest, I was involved in a graduate training. I was a coordinator of graduate training. I was trained by the best, I believe, in the early 70s using balanced occlusion. But I begin to question, can I truly balance a set of teeth in the mouth? Sure, it looks good on the articulator if you're doing that. However, there are so many different parameters when you're trying to balance teeth. There are occlusal determinants, there is soft tissue. It may look good on the articulator, but when you come back into the mouth, have you truly balanced that occlusion? So from my perspective, the lingualized scheme of occlusion is good. And I'd recommend an excellent article. It may be a little old for you guys. Brian Lang wrote an article in 2004 on denture occlusion. It's an excellent article. I discovered this, and I tend to refer back to him because I think there's a tremendous amount of information in that, and it discusses occlusal schemes and tell you why you should be using a lingualized scheme of occlusion. So in addition to the fact that you're using resins, there are biohygienic studies. And I want to emphasize these biohygienic studies, that if you look at a traditional denture process, you're going to see porosity and you can grow candida. If you look at the Avident denture process, and I believe this really relates to all pucks which are truly milled or truly processed correctly under high heat and pressure, you are going to find it is important that all of these, the micro leakage, the shears, the fit comparisons are all going to be very similar. That's what I think. The denture-based fit, Goodacre at Loma Linda did a study, and he found that on the Avident anyway, that there was significantly higher retention for the milled denture bases compared to conventional heat processed denture bases. And this is because when you make an impression and you scan an impression and you mill to that impression, you're getting exactly what the impression has given you. Whereas if you process on a stone cast, the stone to water ratios may not be incorrect. The stone cast may be incorrect. There's going to be shrinkage. So one would expect this to be correct. Are there any questions at this point? I know I've gone through that very quickly. I'm hoping that maybe a movie will come up. Any questions?
You have one question that says, how good will be the suction of these dentures?
Okay, so let's go back. I think we've just done that. Oh, there's the answer for you. The suction is excellent. There's higher retention in my clinical experience. And again, let me just say to you, you know, it's very interesting. What I'm telling you is anecdotal. I can only tell you what I find in my office. There have been very few results comparing the milled prostheses to conventional, which actually would be quite difficult because you have, if you took 30 patients, none of them are going to have the same ridges. But it has been our findings, my colleague, Dr. Olin in Minnesota, has actually introduced this to the undergraduate students there. They've done over 500, and the reports are that the retention is quite phenomenal, and that the denture bases fit very, very snugly. So again, as I say, no research, comparative research, only anecdotal. I hope that answers the question. So what are the benefits to the patient? Obviously, if you're reducing, you can reduce the chair time. We think they know that there's a superior fit. Most important, you have a permanent record. If you're scanning and you have the design of the denture, the patient loses that denture, we know that within 24, 48 hours, you can get a duplicate denture back by anybody who is from the company that has milled this. I can also decide how many teeth I like on a denture base. 4 teeth, 3 teeth, what scheme of occlusion, and all of this is being done by your labs or by Evident, whoever is doing this for you. And as I said, no need to go out and buy that $40,000 milling machine. So the required information is the same. You need an impression, you need a jaw record, horizontal jaw record, you need the correct vertical dimension. And as we develop this lecture, you'll see that you can use averages, because I'm going to show you how you can use averages when making a 3-appointment denture. And if you insist on doing an aesthetic try-in, you can. Something which we're also finding, many questions come up and they say to me, dentists will say, well, what about aesthetics on this? Because you're having the technology, or you're setting this using software, a software program. It's interesting. I told you, Dr. Olin and I are doing some studies. I'm not going to give you the exact figures that we're seeing right now, but I want to assure you this, that most dentists, many dentists, do not select their teeth, and the laboratory technician is selecting their teeth. So aesthetics doesn't seem to be a major issue, really, in many dentists' office. So I can replace a set of existing dentures in one visit. I can replace a lost or broken denture. So how do we do this? And you're going to see that you can utilize the techniques that you're already using in the office. The 4 techniques that I use are, I can do a reference denture where a patient will come in with their old denture. I will duplicate this, make an impression in the duplicate denture, decide to use some composite resins or acrylic or something like a jet resin, which is an autopolymerizing resin, change the aesthetics if I want, change occlusal planes. This can be scanned. I'll send this to Evident using their system called Evident Technique, where you send them an STL file. They can scan it. They'll feed it into the software. They'll send me a digital preview, and I can go to finish. Or I can scan old dentures with records, and you can use an intraoral scanner to do this. I can use occlusion rims, or I'll show you how we do what we call an all-on-6. So I can use a duplicate denture with impressions. I can use a soft material. I can use an old denture, make records. All of this can be scanned. I've got the information. I have the correct vertical dimension. And so from there, I can set teeth, virtually set teeth, and send that to a milling machine, have the dentures, have the base milled in the same puck. I can go ahead and have sockets milled and then pour a white resin into those areas and come back and mill teeth. I can use occlusion rims. Again, you see I've actually got occlusion rims here, which I've impressed from an alginate impression, set up a transparency, decided what 2 sides I need, and I can finish that way. And in this patient, I've actually made an impression, taken a duplicate denture. I didn't like the impression, made an impression in the duplicate denture, made a jaw record, and sent that off. So I'll assess the patient's old denture. This is the reference denture procedure. It's simply a duplicate denture. I call it the easy Evident because I'm doing it in 2 visits. I'll check the vertical dimension and then decide whether I'll be able to make a duplicate denture and use it as occlusion rims. I duplicate the denture, complete a wash in the denture with a light-bodied impression material, add wax to increase the vertical dimension. I record a centric relation position at the established vertical dimension. And let me show you an 88-year-old patient. All they were unhappy with the anterior teeth. There we are. And I like to show this patient because this was the very first patient I actually did using the duplicate denture technique. I went ahead using a thermoplastic tray, made an impression. I duplicated the denture and I made a soft wax. I also did a wash in the denture. And in this instance, I scanned the wash, scanned the impression. These were married by the software. A virtual mounting was completed. There's my jaw record. And what I did on my duplicate denture was I simply added some composite resin. This was my first attempt. I didn't like it. I came back. I could have added a little bit more composite resin to the lateral. Essentially, I'm doing a mock-up. And what I'm going to get back now, after this is scanned in the mouth, in the lab by putting in a scanner, takes 7 minutes. And then the technician is trading off a spatula for a mouse. He's got his software, impression is scanned, record is scanned, the opposing arch is scanned. This is mounted. The two files are digitally overlaid. There we are. There's a mounting. Your technician's saving an enormous amount of time. You've got a virtual base plate, which is mounted. You can decide on the buccal roll thickness, base plate thickness. You can enhance the rugae, and if you want to add the post dam. You can now decide. I didn't have a video. Unfortunately, the videos don't play, but this is what you're doing. You're hitting a button and you're getting teeth into a position. The occlusal plane is set from the anterior, incisal edge of the anterior tooth up 2/3 of the way retromolar pad. And the occlusal design can be set according to what you say in your script, or alternatively, the technician will go ahead and by default will give you a cusp to fossa relationship. You can now customize the aesthetic zone. There is the base that is being set up, and this will now be sent to a milling machine. So there are some parameters which you have. An overbite of 1.5 millimeters, overjet, curve of Spee, curve of Wilson, and there's no randomization here of deciding whether you should change the occlusal plane at all according to your prescription. And these are built into the software. So I'm going to skip that.
Now, from Global Dental Science,
oh, there we are, it is working.
Evident Digital Dentures comes an exclusive full design software suite that lets you design Evident Digital Dentures to your exacting specifications. Eliminate the arduous work of traditional setups and simplify your workflow within a precise digital environment. With Evident Design software, you have the ability to make global functional design changes on your Evident right down to minute single-tooth aesthetic enhancements. Starting with the global functions, Evident lets you change the arch form. By simply moving the slider controls, you can verify that teeth are properly placed over the ridge. Change upper and lower posterior roundness of the arch. Change the upper and lower anterior squareness of the arch. Exclude posterior teeth as needed. Decouple the upper and lower arch to achieve crossbite and edge-to-edge setting. Adjust overbite and overjet to accommodate class 1, 2, and 3 jaw relations. Change the anterior slope of the denture for single arch design. Avident Design Software maintains the arch form while offering you additional refinement options with group-based tooth movements that allow you to rotate the upper 6 anteriors about the long axis of the teeth to achieve a softer or bolder look. Lower or raise the lateral incisors. Change the position of the neck on the upper 6 in or out while maintaining the incisal edge. Adjust canine distal flare. Adjust canine neck, mesial, distal, buccal to lingual to create proper aesthetic. Lower 6 anteriors globally move the neck, buccal to lingual. Flare lower canines, buccal lingual. Adjust the curve of speed. Adjust the curve of Wilson. Adjust the posterior vertical to affect the plane of occlusion. Finally, Avident Design Software gives you additional aesthetic controls that lets you create diastomata between all anterior teeth. Move an individual tooth in the following ways. Buccal translation, coronal translation, buccal neck rotation, distal neck rotation, distal flare rotation. Or you can move an individual tooth and mirror adjustments of its complementary tooth on both sides of the arch. Once the design is completed, Avident will reset the occlusion and your Avident is ready for milling. Now, put the power of digital design in your hand with now from global.
Okay, so what you get after that is a digital preview. And I think what I've shown you really depicts software. The technicians that I work with love it. From my perspective, I have in my office the software which I can actually change teeth if I wish to. And this is saving an enormous amount of time. So here we have the completed restoration now. As I said, this was my very first denture that I did. It was bonded teeth. Here we have, she came in with her teeth. This is what we waxed them to, final aesthetics from the duplicated denture. This is the old denture, and there we have her final restoration. Sorry, the numbers I see are not exactly depicted correctly, but very easy to do. So on this patient, my next patient I want to show you, I compared bonded teeth to milled teeth because I was very, very interested to see whether or not there would be a difference in appearance. I was very interested in the milled teeth. This is a long denture porcelain teeth. The denture had been repaired, and you can read this. But most importantly, I worked in a different two dentist office, and this happened to be the mother-in-law of the one dentist. And he said to me, there's no way that I'm going to be doing my mother-in-law's dentures because I'll never live down. She happens to live in a different city. We're in New Orleans. How are we going to manage this? I said, don't worry, Jim. We're going to do it in 2 visits. This is the patient as she presents. And I looked at her and I said, oh, look at the buccal corridor there. These teeth have to come out. I'm not going to try and overextend this denture. I'm going to give her what she wants. I don't need to change the vertical dimension too much here because we don't want to change too much. She's been so used to wearing these dentures for over 30 years here. So let's see how I'm going to do this. So I decided, I'm going to duplicate this denture. I noted the thickness of the borders. I decided that the front teeth needed to be a little longer. I put this into the mouth. There is my duplicate denture. I built up the anterior teeth. There's the buccal corridor, which needs to be, I need to add some resin. So I'm calling these my record bases. These are the duplicate dentures in the mouth. I still haven't, I've made my impressions in the dentures. As you can see, suddenly I've added some composite resin back here. I've added composite resin and I've taken a jaw record. I've decided where the midline is. I'm indicating where I'd like some teeth. I'm going to say that I'd like to have that size tooth. Avident Connect, I'm sending this to Avident Connect. If you want to go through a lab that deals with Avident, you can go ahead and do that. If you want at this point to use an Ivoclar puck, you can go ahead and do that and utilize a lab that does that. I've used Ivoclar. I've been very privileged to be able to use Lee Culp's lab, the Sculpture Studios out in Cary, North Carolina, and I'll show you a couple of those cases. They've turned out great. Because of shading, Vita is the universal shade. Avident have come up with different shade guides and matched it to the Vita shade guide. These are her new dentures. And on these dentures, I'm using portrait teeth, which is a Dentsply tooth. And as I told you, I didn't try and change the shape of the base on this one. There are the denture teeth with manufacturer's teeth. These are bonded into place. In other words, there were sockets developed, and there's a lingualized occlusion. I couldn't get her back, but she does have a lot of lipstick over there. But as you can see, it's a lingualized occlusion. And there's the manufacturer's tooth. There she is. Now, after the denture, her profile has improved dramatically. There's the manufactured teeth. And then I said, you know, I have a captive patient here. I can send her home with, she'll come back in a couple of weeks and I can make her another set of teeth. And I decided that I wanted to make her a totally milled prosthesis. There are different colors of the Lucitone tooth material that Avident does. It does Lucitone, it has its own vertex. And I went ahead and used the Lucitone tooth colored material. This came back, these are milled teeth. They look very, very aesthetic. And there we have the XCL1 tooth. I told you can get XCL1 or XCL2. The difference with a milled tooth as compared to a bonded tooth is that you can almost see a slight connection between the tooth here. Now, one of the issues obviously is what happens if you break one of these teeth? How do you replace it? Thankfully, in my practice so far, I haven't had to replace one of those. And I dread the day that this is going to come in. COVID may hasten my retirement here, so the other dentists will have to deal with that. But let's have a look. If you look at this, lingualized occlusion here. It's a monolithic denture. There's the XCL. There's the portrait teeth. And the patient actually chose this set of tooth to go home with. And she lives 300 miles away. And that was done in 2 visits. Okay, this is a patient who had a denture made 3 years earlier. Rather than relying, he requested a new denture. He requested a new denture. Here's the duplicate denture with I made a duplicate denture of his old denture. There's the duplicate denture, impression, scanned. And there's the final denture. And this gentleman, also a dual laid IPN. Now, what I want to talk about right now, look at the time that we're saving. Certainly, I don't know, in my office, it takes my assistant exactly 18 minutes to duplicate a denture. We've worked out the ratios of the resin. If you want to leave that for a week to set so there's no shrinkage, you can do that, or you can utilize it immediately. I go ahead, do wait a period of time, at least a week, get all the shrinkage. Patient will come in next time. I will use a wash, or I might use a soft lining material. I haven't had any problems in scanning this or even sending it through the mail. And then I will make an occlusion rim, or I'll have the duplicate, as I said, make a record of this, adjust the teeth as I've shown you, and then I will go ahead and have a denture constructed. Well, what happens if you have the patient's existing denture and you would like to change that and utilize an intraoral scanner, which you have in your office? You might have the Trios, you may have any scanner which you can scan. You can do that. You can scan the jaw relation record. If you're doing 2 dentures again, you can scan, change them in the mouth, make your jaw record, and send these off. And lo and behold, you can send this to your lab. You can send this to Evident. You can get a denture back in 2 visits by simply utilizing the patient's old dentures. There's the patient's old dentures. You know, you can go ahead and improve the vertical dimension. This is not her dentures. I've put something in. I did not have a picture of her old dentures, but I think you're getting the idea here. You can see I've made an impression with some Co-Soft. I've washed the upper denture. You scan the inside of the dentures with the reline material facing up. You scan the teeth, scan the bite. There are 5 scans that you can see that you've sent, the dentures, and you can get your denture back. You can check your incisor guidance, and this again is in 2 visits. So many dentists, I'm not going to say all of us, have an intraoral scanner because you're using that mainly in your fixed prosthodontic, fixed partial denture areas or single crowns. You can use that same scanner and apply it now to your denture construction. You can send your STL files to a different lab. It doesn't have to be Evident. You can send it to Evident. You can send it to somebody who is doing a printed denture for you. And you can utilize your scanner now and look at the advantages that I've just shown you. You're making an impression. You have the patient there for a captive hour maybe. You're not bringing the patient back for a jaw relationship record. You're not bringing them back for a second impression. You're not bringing them back for another try-in. You're doing all of this in the confines of 1 or 2 visits. And again, I go back to this factor of, well, what about the aesthetics? How will I view this? Yes, there is a learning curve, but if you use anatomical averages of knowing where the incisors papilla is, anterior teeth should be 8 to 9 millimeters forward of that incisor papilla. And I will show you as I develop here, we'll go to a 3-visit denture, which many of you might want to do, and we'll call it the all-on-6. Now, some of you might say, wait a minute, I still like the old technique of using an occlusion rim. That's fine. Go ahead and make your final impressions if you want to. You can decide to use occlusion rims. There we are. From your alginate impressions, you do your impressions. You have a lower impression here. You can use an occlusion rim off a final impression and pour a stone cast if you want to, or you can use an occlusion rim and do a wash in an occlusion rim. And then you go ahead, do your base, use the transparency that Evident have. There are also different materials on the market. You can use you get small resin try-in, which has tooth size preformed resin mock-ups of teeth, which you can stick onto your occlusion rims. Using the software that I showed you in the movie, you can go ahead, get your teeth set, get your denture finished. This is a final denture with bonded teeth, and you finish up. Now what I want to talk to you about, and this is the technique that I tend to use now because it gives me the opportunity of doing my aesthetics in the mouth if I so desire. The 3-appointment denture, which I think many of you will enjoy doing. I use a thermoplastic tray to make a final impression. You can get these trays. These are available from most companies. Shine sells them. Just go online. They cost about $3 a bit. I utilize a border molding material, a medium. I border mold my tray and then I come back with a wash. There is the impression of the lower. And what the whole concept is here, you can either get back a printed base with 6 anterior teeth on the top, 6 anterior teeth in the bottom. There are different ways of doing this. You can also get a whole printed denture. You can get back a milled base with milled teeth, individual teeth, but you now have control in your office to set teeth. Now, I've got to tell you something. In this new environment, which I'm finding myself, is that I'm beginning to think that doing a digital denture is going to be tremendously to my advantage. I'll do a duplicate denture if the patient comes in with their old denture. I will do a mock-up in the mouth, and I'll go to finish. So I won't have to sit at my bench in the office, taking gloves off and on, burning my fingers through rubber gloves and setting teeth. So the advantage of this is that I now have a stable record base and I have 6 anterior teeth. And you might say, well, how do I find the position of those anterior teeth? Ivor Claw gave us an analog system of how to make dentures. If you go back into the dental literature many, many years, the incisal papilla, the position of the incisal papilla in relationship to the anterior tooth is a landmark which you can use. The anterior tooth, the upper anterior tooth, the facial aspect is about 8 millimeters forward of the incisal papilla. So if we know that, and we're setting teeth digitally, you can set those teeth 8 millimeters forward, the facial aspect 8 millimeters forward of the incisal papilla. And what about the length? We know that generally the anterior tooth, depending upon the lip length, is about 1 to 2 millimeters below the rest below the margin of the upper lip. So why not measure the length of the upper lip at smile line and at rest? You're beginning to get an idea also of the length of the tooth. So here we have the papillometer, which is going to be used. We measure we don't do that. We select a tooth shade. And let me give you an example of how this is done. This is a 62-year-old lady who has had melanoma and breast cancer. We make upper final impressions. Our measurements, there's the incisal papilla. Place this on the incisal papilla. We can see the landmarks on our papillometer. We record the length of the upper lip in millimeters. We go for a smile, and those two are sent to our lab, and those two are sent to Avident or any lab that you're using, which software they're going to use. What we do know is that generally the occlusal surface of an upper molar is about 10 millimeters inferior from the pterygomaxillary notch. So if you have your impression and you have the position of the incisal papilla here, you know where your anterior teeth are going to be, and you can set an arbitrary occlusal plane. Set one molar, and on the lower arch, give yourself the luxury of setting 6 loose teeth, 6 individual teeth. This is what the technician is now doing. He has a virtual mock-up. He sends you back a base with 2 molars on it, some anterior teeth. And what we're going to do now is we're going to try these in the mouth. And you'll see my modification as I move ahead here. These are in wax. What happens if I don't want them in wax? Well, I can do a printed denture with teeth, or I can do that milled acrylic base and adjust those. Here we are, we're adjusting the teeth. We're going to check the campus plane, the allotragus line. Make sure that we have an occlusal plane. We check our Fox plane, as I showed you. These are techniques which we're all used to. Trying a movement of teeth. If you want to set these, you can take away the wax and put a composite resin into there. Set the teeth in composite resin if you don't want to change these. Trying a movement of teeth. You now position the lower tooth. We have the midline. It's not essential to put the lower tooth into the midline here. All I want to do is get the tooth position according to aesthetics. I have a very stable base. I now make a record. And in three visits, I have a denture where I've used average measurements. I've used a stable bases, set anterior teeth, and now get back a permanent prosthesis. What I'm sending back to Evident or to your lab, or I can scan it, and I'm giving you these three options all the time. Because if you don't have a scanning machine in your office, your lab, or you go back to Evident, they can scan your records for you using the technology and the software which I showed you in the movie. I'm glad that one happened to work. And we get back a denture, and there it is in the mouth, and the patient has. So we now turn to another patient. I don't know how many of you have been around. I know Dr. Gog has been around. I'm sure he's not here. I hope that he's out in the golf course somewhere playing golf. He deserves a break. But in 1976, I was doing carbon implants. This patient came in. It's been my practice since then. We've done a lot of preoperative, pre-surgical procedures on him, but he still remains edentulous and doesn't want to have any more implants. So let's have a look at this. We're going to make first appointment impressions, second appointment records, and third appointment delivery. He happens to have 2 implants. There are the impressions. You can see the imprint of the implants. And look what I did at the time. I'm actually putting occlusion rooms onto the impressions which I've made. I've got a real good base here. I can make records. I make my measurements. Ask the patient to relax the upper lip. Record the position of the upper lip smiling. And I get this is the NextDent printer. I'm getting back a printed try-in denture. This looks very much like that duplicate denture which I showed you. Now again, I want you to envision the time here. How much time did it take you to make those final impressions? How much time did it take you to simply add wax? Make a jaw record. You've got all the information that you need here, except for the aesthetics. So you get back a printed base. The printed base is tried in the mouth. You can adjust the vertical dimension at this point. You can adjust the centric relation position at this point. Very easy to grind down a printed denture. I use the same wheels that I use on my printed denture to cut my printed denture as I do to polish a denture. I get back an Evident monolithic XCL2 denture. Now, what don't you like here? I don't like the color at all. At all. It's too white. The occlusion is good. I pip it in the mouth. I pick it up. Very interesting. This serves a case in point. Because you don't like it doesn't mean to say the patient doesn't like it. Very interesting studies in the literature which show that patients tend to be much happier with prostheses sometimes than we as dentists do. We criticize our work far more than any other profession. There he is. He's really happy. He's got 2 implants. He actually had a very bad bleed after one of the implants failed, and was actually helicoptered to hospital because of that. And I think either one artery had been nicked, and so this is a good lesson for all of us to learn. So I told you those are the Avident dentures. What about Ivoclar? You know, I said to you in the beginning, I'm not selling any system. Please understand that. And I want to emphasize that I've used Avident, and now I want to show you the Ivobase. The Ivobase is similar. There we are. You see a base that has been prepared or milled. There are sockets. What difference between the Ivobase and the Ivoclar system is it comes with all the apparatus that you need. It has an analog system. This is a measuring device where you can measure the position of the anterior tooth in the old denture as it relates vertically and horizontally. You get your papillometer. And the difference also is that they have a face bow, essentially a face bow, which gives you an orientation in the mouth. I've only done 4 of these. I particularly haven't found that to be too useful, and I'll show you what I've done. What you see here is called a centric tray. So again, the analog system calls, and they've simply converted this to their digital system. You use the papillometer. You get the rests on the papilla. You see the lip at rest. You have a high smile line. You make your final impressions. But in addition to that, you use your centric tray with a hard putty, and you try and get your patient into the correct centric relation position at an established vertical dimension. And so what you're doing here is that centric vertical position is going to be scanned, and a virtual mounting is going to be made. Using your papillometer readings, there we are. This is what I've done. I've kind of demarcated where I think my occlusal plane is going to be, as you can see it over here on the patient's mouth. There is my centric relation record. Now I can scan this. I can scan my final impressions, and I can relate this and make a virtual mounting. Using a virtual mounting here, I can now set my teeth. I know where the incised papilla is. I know where the occlusal plane is going to be. I know what type of occlusion I'm going to use. I know about my incisal edge position, my horizontal and vertical overlap. If you want to use the face bow, you can. This attaches to the centric tray. You go to a go-to meeting with your technician who's setting this up. You decide whether you like the setup, and hey presto, I get a printed Trine denture. I'm going to try these in the mouth now. Very much like my duplicate set, but this is a little bit, I've got a real stable base here. These are my printed denture. I found that my vertical dimension of occlusion was high here. It actually fit very, very well. It was interesting to note that the centric relation position that I've made was almost spot on. And here you can see I'm adjusting the lower denture. Not shy to do that. The instrument that I would use to polish, I'm making a final jaw relationship record. I didn't like the aesthetics. I took some of the material down on the anterior position here, the S position. I thought my teeth were a little bit too far forward. Again, go to meeting. Now we can finalize the setup and note the characterization of the anterior teeth here. There is the position of the anterior teeth. Facial and lateral views of the final denture, and there it is in the mouth. And she's very, very happy. She liked the fact that she could see the buccal corridor has been decreased in size here, and from an aesthetic point, she was very happy. It's a very natural appearance on the anterior teeth. And you can see good characterization here. Now, how is this done? Well, with the Ivoclar system, originally, and I'm going to talk about this, the base was milled, and then the teeth were milled, and the teeth were inserted onto the base. What Ivoclar have done now is, if you can imagine, you have a puck of resin, the base is milled, and sockets are milled. White acrylic or tooth-colored acrylic was then poured, and the puck was remilled, and the teeth were milled from that, and then placed into the socket. Now, Ivoclar have come out with a puck, and they're the first ones to do this, which has pink resin on the one side, white resin on the other side, and you'll be able to choose your shade according to their shade guides, which they have. So this is another patient which I just wanted to show you. This is an intraoral view of a printed tri denture. This is the carbon material which the lab is using. There's the milled maxillary and mandibular final denture. And what I wanted to show you here, note the finish of the milled resin bases here. There is the completed restoration in the mouth. And this is our happy patient. Obviously, being in Louisiana, if you don't have an LSU shirt, I happen to have an Ohio State shirt, the Ohio, because that's where I did my training. And every season I come into the one office, I hang it up, and I don't take it down until the season is over. Haven't been too lucky of late. So what I wanted to show you here was a difference. There is an Ivoclar milled denture. There is an Avident dual layer denture. Depending upon your desires, you can choose the system that you want. So what we have here is an adaptation and adoption of technology, which we can use. There are alternative records. I have found success doing a two-visit denture using an occlusion room. I utilize what I can have at the time. If I don't have a denture which I can work on, I'll make my impressions. I'll add wax, as you saw, to my impression trays, make a jaw relationship record, and I have 2 visits in one. And then I'll either have a functional try-in or a printed completed restoration to go ahead and complete my denture. Well, what else can you do? What about immediate dentures? I know that patients come in with all different schemes of occlusion and numbers of teeth. Avident can provide you, after you have sent in records, with a tray and with a surgical tray which you can use. This happens to be another patient of mine, had breast cancer. She had a bypass, and I needed to do an immediate denture. So I made alginate impressions on this patient. And you can see that I've got an overextended impression here. What I'm going to do now is just add some base rims and make a record. If I had sent this to my lab now, what we would do is I would set teeth, verify my jaw record, and to finish, he's going to have to go ahead and cut away stone teeth, waste time doing that. Or alternatively, why can't I do this? Why can't I scan those casts and the jaw record into using software, have a virtual mounting. These can be rounded, the ridges can be rounded off. I can indicate on my prescription where I'd like pocketing to be removed. Teeth can be set. I can agree, and I can get my dentures back for immediate placement. You can see that Avident have placed the patient's name into the denture. There is the upper, there is the lower. I know these are Avident. These are milled teeth on a milled base. I mean, a bonded teeth on a milled base. There is the day of surgery. and that's completed. Now, what is of importance to you guys, obviously, are can I use these for implants? And what I've done here is I wanted to show you the technology, and I wanted to show you that you do not have to go out and get all this expensive equipment. You probably have a scanner in your office. Why not use current technology where you can reduce the number of visits for your patients, where you can make a monolithic denture if you're going to use this for your implant restorations, and truly become part of a revolution here, which I believe is going to take over, because our technicians are going to say to you, you know what? It's easier and quicker for us to go ahead and do a milled prosthesis or a printed prosthesis. Now, something else from the National Association of Dental Labs that I read was that there's been a decrease and there is a slow decline of the number of mom and pop labs in our country, and there is a decrease of the number of labs in our country. So much work is being sent abroad, and it's very interesting. I often say to patients who are doing zirconia restorations, full arch restorations, I say to them, well, do you know what additives have actually gone into your zirconia restoration? No, we sent it abroad. I said, well, you know exactly what you're putting in the mouth. And this is one of the issues that I have when work is sent abroad. And I'm hoping that if my US colleagues US state colleagues will actually use labs in our country, because I think we do provide a better product if you're doing this. So let's have a look at implant overdentures. Now, there are a variety of different bars and superstructures which you can have. Avident have developed their own system. It's a snap pin which you can use. This is a patient on whom a snap pin is used. There is a superstructure with 4 little pins. I'm going to be very honest. I've only used one of these. I wanted to use it to see how it works. Generally, if I'm doing an overdenture on 3 implants, a large overdenture, I'll use a bar. I'll either use a locator attachments. I like that because a locator attachment is used universally throughout my country. And if my patient leaves my office and goes to another city and needs for that attachment to be serviced, then the locator attachment can be serviced. The other attachment that I like, Avident can do this. Certainly most labs can do this. If you're doing a milled prosthesis and you're putting in a superstructure, you'll do it. I like to use hinge attachments or the loop passive attachments, and I happen to like a spark erosion. I know this is difficult to do with the milled type restoration, so in that area I will obviously be using the lost wax technique. The other thing I want to emphasize is, hey, this is a great technique to be used. I have not thrown out the baby with the bathwater. I recognize many times that there are patients on whom I may have to do some subtle aesthetic changes on a denture. I'm starting practice next week, and next Thursday on the 21st, I know at 1 o'clock, I have a patient on whom we did 5 try-ins. We've delivered the prosthesis, and she is still unhappy with the prosthesis. Thankfully, I didn't try and do a milled prosthesis because I know I'd never have achieved the aesthetics. This is a patient who walked in with the Vogue magazine. She wants toilet white, bowl white teeth, as we all recognize. So we all have those problems. So I do use the lost wax technique. And this is the patient with the upper partial denture against that pin denture. And then, of course, there's guided surgery. I do hybrid dentures in my practice on my dentureless patients for those who need it. I'll be wrapping up quite shortly. I realize So just bear with me with this remark. It's become commonplace in my practice now, where I have a patient who comes to me after wearing dentures for many years. If they've been wearing dentures for many years and are edentulous, and my surgeon sends them over and says, how about doing immediate load? My response generally is, if they've been edentulous for 20 years, another 3 months isn't going to harm them. Put the implants in, and then I'll make the prosthesis once. The other thing, which I think is very, very important, is to decide, when am I going to, at what age do I give a patient a fixed prosthesis or a removable prosthesis? And in my practice, I have come to the decision almost that patients who come in who are over 70, 72, 73, and are coming in for something truly very stable and retentive on the lower, and they want to have implants, I'm tending to go back to what I started with, and that is a removable restoration. And let me tell you why. I've had a number of my long-time patients, and I've also had patients who were not my original patients, come to me with third-party caretakers. And what we've seen tremendous deposits of debris around fixed dentures, broken teeth, and I'm now left with the position of having to remove these and then take care of these. And I'm in the position now where I have to get these back, and the caretaker cannot look after these. So you may laugh at this, but if the patient is 74 and wants a fixed restoration, nothing wrong in doing a large removable type restoration, which is fixed by attachments onto a bar. The caretaker can clean that denture. If anything breaks on that denture, it can be repaired. And I believe we need to rethink some of the way we treat elderly patients. I'm 75, 76, so I recognize this. And in some of my patients who are elderly, who have been wearing hybrids for a long period of time and need to have these, quote, retreaded, I'm also transitioning over to removable restorations for that exact reason. To some of you, this may not make sense, but in my practice, this is how I view my patients. And so this is a patient. This is a denture that has been sent back. This is a monolithic denture that will be done for an immediate load, which I've done. I like to use guided surgery if I can, because there's minimum bleeding. Also, the denture that is prepared by Evident has slits in it. There are the implants in position. Very easy to come back. I used a jet resin here to pick up my copings. I can see exactly how much resin I needed. There is both upper and lower. It's very easy to reduce these. I utilize that to make a cast, which I'll have for future reference. I have an index. There is the transitional denture on the day of surgery being screwed. There's very, very little bleeding when you're going through the tissue and doing guided surgery. And then for the final restoration, here is a milled bar. The milled bar, Evident have a very interesting proprietary system of placing a milled bar in position. They will make the denture first. They have slits and they position the denture, what we call it, retrofit the denture into position. So there's retrofitted into the denture. It is cured. There is the final prosthesis, and there is the final prosthesis in the mouth. I just threw these in because I know that this is an implant group, and you might say, well, how is it going to affect me? Essentially, my task was to talk about the digital denture. Obviously, I'm utilizing this for implant overdentures. These can be milled. I can pick up locators in the mouth. I can make my hybrid prosthesis if I want to out of resin and tie. Well, old habits die hard, don't they? And CAD/CAM dentures, there's every excuse not to use them. But in my practice, I'm finding that it does save me an enormous amount of time. I can do records, I can have them milled, I can do immediate dentures, there's virtual tooth setting, and there's immediate loading. What I wanted to do quickly, though, to add to this, I've had a lot of questions from colleagues in New Orleans. Well, what happens? Are you doing printed dentures? So let me go through this very quickly. One case to conclude here, and this completes the cycle. You have different materials, different companies. The patient had an existing denture. This is what the existing, when he came in originally, this was an existing denture. He liked his small teeth. So I want to show you what I did. I duplicated the denture. I made impressions in the duplicate denture. This is in 2015, I believe. There were the scans from the duplicate denture at that point, and I finished the dentures at that point, and these were new dentures made by Avident in 2014. He came back in 2019 and wanted a new denture. I duplicated that denture, went through. I'm not going to go back to Avident at this point. I thought to myself, let me try seeing what a printed denture makes. I took casts of his old dentures. I made records. This is ExoCAD. I looked at the previews that my laboratory sent. These were the first set of try-and printed dentures. Those were his current dentures that he was wearing. This is the try-and. You can notice from a duplicate denture, from the cast, everything has been scanned. This is, I got the lab to make some pictures just showing you the printed denture. There are the sockets that are milled into the base. Something which I still don't quite understand about the printed denture is how they actually get these to stick into the base. It is a light cured material, I understand. There are the final printed dentures. These are completed. Do I like the aesthetics? No. Do I like the fact that I can actually see the attachments? No. Do I like the fact that I can see some translucency over here? There are, when I talk about monolithic here, these are monochromatic. Do I like them? No. I'm sure as time progresses though, but if you look at the smile line here, doesn't look as bad as I'm making out. These are delivered. Did I like the occlusion? No, I did not like the occlusion. Was that my fault? Probably so, that I didn't get a good jaw relationship record. So another patient, just to complete. This is the patient's old denture. There's the patient's old denture. You can see it's quite worn down. I made impressions in the patient's old denture. He had 2 implants. I went ahead on the base, on the old denture, used some wax, made a record. I adjusted the upper teeth. As you can see, I've added some white wax. I'm using ExoCAD. I got a printed denture for trying. Again, this is a 3-appointment denture. This is a class 2. I didn't like my lower impression, so I remade it in the printed try-in denture. There is the final denture. I used a material to locating houses were picked up in the lower denture with the resin, mind you, and there it is. So if there are any questions, I'm more than happy. This has been a very quick overview. I'm sorry some of the movies did not decide to work. I would have liked to have shown you a few more movies. If there are any questions, I'm happy to take these, but I would go ahead and say to you, I would like to encourage you, don't be shy to try this system. A lot is available on the market. If you have a scanner in the office, technology is moving very, very quickly. Different companies are offering, different labs can do this for you. It's been a pleasure to be with you. Be safe, stay well, and if there are any questions, I'm happy to answer them. If not, all of you keep well. Thanks very much.
Thank you so much, Dr. Finger. That was an amazing presentation. We do have one more question over here, and it says, how do you check phonetic and digital dentures in a single visit?
How do you what? Check phonetics.
Yes.
Okay. If I'm doing, oh, you mean if the patient has their own old dentures? If you're doing that, I generally will, as I said, duplicate the patient's denture. I will then go ahead and verify how far forward that tooth is from the insides of a pillar. I will add a composite resin or something like a temporary resin such as jet resin. I will position the tooth and the edge of that tooth according to the vermilion border of the lower lip. I will use the S position against the lower tooth. I will use the fricative sounds to go ahead and help check position. And then I'll use the bilabial sounds such as M, B to check the vertical dimension and also verify the position of those teeth. And that's how I check phonetics. I'm not shy to add resin, subtract resin to find the position of the tooth. All I need is a block of resin and a midline. And from there, I will choose the size of the tooth, or I will allow the software to choose the size of the tooth. And that's how I will check phonetics. No difference to any other way that you might check phonetics in the mouth with an occlusion rim or if you have teeth in the mouth. Okay.
Awesome. I think that is it for our questions here on Zoom. Thank you so much, Dr. Finger. We really appreciate you taking time.
Say hi to Dr.